Hello, Patho students. Welcome to this discussion of disorders of fluid, electrolyte, and acid-base balance. When we consider body fluids, we categorize them as either being intracellular or extracellular. The intracellular fluids are fluids within the cell, so within the cell wall, but the extracellular fluids consist of fluids within the blood plasma or the vascular compartment, and the fluid that lies in the spaces between the cells, which we call the interstitial spaces. It also includes something called the transcellular component. And this is fluid that is in cavities such as the peritoneal cavity or the fluid around the gut. Also the fluid in the pleura of the lungs, the fluid around the heart called the pericardial fluid, and also the synovial fluid or the fluid within the joints. Most of our body fluid, about 2/3, ends up being within the cells, while only 1/3 or so is in the extracellular fluid. And if we think about that third of the extracellular fluid, we're looking at about 1/3 of that being plasma, while the other 2/3 are in the spaces around the cells or the interstitial space. Water makes up about 60% of a healthy man's body weight and about 50% of the body weight of a healthy woman. This proportion will change in obese persons who tend to have more extracellular water compared to intracellular. In babies, water is responsible for about 75 to 80% of their body weight. They are also more susceptible to dehydration since their body surface area is larger in relation to their weight, and their immature kidneys are not as good at concentrating urine as an adult's would be. Fluid shifts in and out of cells rather fluidly. Our capillary beds provide a really good example of how fluid moves from extracellular, in fact the intravascular space, to the interstitial space and vice versa. This slide depicts two types of pressure that you need to know. The hydrostatic pressure is the pressure that tends to push fluid out of the capillary. So if you were inside the vascular space, then the pressure that the fluid exerts on the vessel wall is a hydrostatic pressure. And you can see in this picture that the interstitial fluid does have some pressure. The net pressure gradient supports fluid moving from the vascular space into the interstitial space. The second type of pressure is the colloid osmotic pressure, and you can think of this as the pulling force. Solutes, which are particles or plasma proteins in this case dissolved in water, will pull water from both the capillary and from the interstitial fluid. Under normal circumstances, more water will be pulled into the capillary unless there happens to be a buildup of proteins or other particles in the interstitial fluid. And we'll talk about that more when we talk about inflammation in the next chapter. But you can see in this picture that the capillary colloidal osmotic pressure is 28, while the pressure in the interstitial space is 8. So again, the tendency is for fluid to be brought into the vascular space. In normal circumstances, fluid tends to move from the capillaries to the interstitial space. So I just flipped back here so that you can see that the pushing force tends to push water out of the capillary. The pulling force, or the oncotic pressure, tends to pull fluid in. But when we look at the net movement, the fluid and proteins, fluid tends to flow from the capillaries into the interstitial space. And if you think about delivering oxygen to tissues, that kind of makes sense, and that's the direction we would want it to go. Fluid and proteins that are not reabsorbed by the capillaries will end up being drained via the lymphatic vessels. Edema refers to an excess of fluid in the interstitial spaces. In your assessment, you will note palpable swelling. The swelling may be localized, as with a sprained ankle, or it could be generalized, as happens with people who have kidney failure. Sometimes your finger will cause an indentation or a pit in the tissue. This is referred to as pitting edema. Pitting edema suggests that fluid flow to the area is somehow restricted. Some causes for pitting edema would include heart failure and blood clots. Non-pitting edema is seen with lymphatic disorders and thyroid conditions. Here are some common causes of edema. First of all, our vascular system could be carrying an increased volume of blood. This could happen as a result of kidney failure, when kidneys are not ridding the body of fluid as they should, or perhaps the heart is not pumping effectively, so the kidneys aren't able to eliminate fluid because they are not seeing enough of the cardiac output. A venous obstruction or a blood clot can cause a localized increase in capillary pressure, resulting in edema of the extremity. Sometimes the edema is associated with decreased colloid osmotic pressure. In kidney disease, protein molecules that would have been retained by the normal kidney end up being lost in the urine. A relative decrease in plasma protein causes fluid to leave the intravascular space and enter the interstitial fluid. This could also happen in liver failure because the liver is not able to make the plasma proteins that we need. Additionally, patients with malnutrition can experience this type of edema because they've lost that intravascular colloid osmotic pressure or pulling that comes from having adequate protein in your blood. Inflammation, allergic reactions, or capillary damage can cause the capillaries to become more permeable. And when they're more permeable, that means that fluid can more easily escape the vascular space and enter the interstitial space. Edema might result if lymphatic flow is reduced or obstructed. And in that situation, the fluids and proteins that would have been reabsorbed via the lymph remain in the interstitial space. Tonicity is an important term that's closely related to colloid osmotic pressure. The ability of an extracellular solution to make water move in or out of a cell by osmosis is called the fluid's tonicity. Fluids that have more particles or a higher osmolarity are said to be hypertonic, and fluids with fewer particles are referred to as hypotonic. In the figure, the circles represent a cross-section of a blood vessel. The first dark circle depicts red blood cells in a hypertonic solution. Note that the water tends to leave the red blood cell I think of it as trying to equalize the distribution of particles, so more fluid leaving the cell to make the solution less, to kind of dilute out the particles in the solution. In the middle picture, there's an equal exchange of fluid in and out of the cell, and this happens with an isotonic fluid. And then note in the last picture, the red blood cells that are floating in a hypotonic solution tend to take in water and swell. The most common type of fluid imbalance is an isotonic imbalance. In nursing diagnosis language, we refer to this as fluid volume deficit or fluid volume excess. Fluid volume deficit is another way of saying dehydration. As you know from your own life experiences, people can become dehydrated by not taking in enough fluid or by eliminating more fluid than is taken in. We can lose fluid through our kidneys, our GI system, our skin, via excessive sweating, and also through third space losses. And that simply means that fluid is moving from the intravascular space into the interstitial, or sometimes we call this the third space. You'll hear people in practice talk a lot about third spacing fluid. Usually our kidneys do a pretty good job of maintaining fluid balance. However, patients, commonly elderly patients who take diuretics, and so with these drugs, we can certainly cause the body to eliminate too much water. It has to be finely tuned. A patient's weight is an important assessment of fluid balance. So what causes fluid volume excess? Basically, when we don't eliminate enough sodium and therefore water, or when we take in too much sodium and water. This could be through diets, through medication, or through IV fluids. And patients who are retaining fluid tend to experience weight gain. Before we leave this discussion of fluid balance, we need to delve a bit more into sodium. As this slide shows, water molecules follow sodium. So sodium balance is critical to fluid balance. Beginning with sodium, we'll start our discussion of electrolytes. Electrolytes are substances that dissociate in solutions to form ions. This slide has some pretty small tables, but the important concept to capture from it is that sodium is the most plentiful positive ion or cation in the extracellular fluid, while chloride is the most positive, the most plentiful anion. Essentially, your cells are floating in salt water. That is why maintaining the right balance of sodium in water is critical to maintaining healthy cells. Normal serum sodium levels are 135 to 145. We've been talking about osmolarity, so hopefully you're realizing how important sodium is to maintaining normal osmolarity and normal cell function. It's particularly important to nerve and other cell functions. Remember, when sodium increases, then extracellular fluid becomes hypertonic and begins to pull fluid from the cell, causing cellular dehydration. By contrast, when extracellular sodium is low, then the fluid becomes hypotonic, so the cells are bathing in hypotonic fluid. In that situation, fluid will leave the extracellular space, enter the cell, and cause cell swelling. Phosphorus is also an important extracellular ion. We need adequate phosphorus for glucose, fat, and protein metabolism, for high-functioning red blood cells, white blood cells, and platelets. And phosphorus also functions as an acid-base buffer. At this point, I just want to introduce the primary intracellular ions, potassium, calcium, and magnesium. We'll talk in more detail about these electrolytes in part 2. Net water losses, or hypovolemia, can happen, for example, due to sweating, makes extracellular fluids hypertonic. And this slide is showing you that a minimum amount of increase in osmolarity or tonicity triggers the pituitary to secrete ADH, or antidiuretic hormone. ADH signals the kidney to reabsorb water. So hold on to water in an effort to offset the increasing osmolarity. Fluid intake from outside the body is also required. And that's why the thirst center is triggered, and that makes people want to drink more water. Additionally, hypertonic cerebral spinal fluid stimulates the secretion of angiotensin II, and that also triggers the thirst response. On the other side of this figure, if there is a water excess, then osmolality is reduced. This signals the to shut off the thirst drive, and also shuts off ADH. And with less ADH, then we no longer are reabsorbing as much water, which means water excretion would increase. In water excess situations, the osmolarity of extracellular fluid, this whole process becomes normal. Becomes normal in about an hour or so. So in an hour of these sensing the decreased osmolality, our bodies can correct a water excess situation. So thirst is an important way that our bodies manage fluid volume. And in the previous slide, we talked about the role of ADH, which is also known as vasopressin, and how it works in fluid management. There are 2 pathologies associated with ADH that you need to know. The first one is diabetes insipidus. Now, this disease is not related to the common diabetes that I'm sure you've all heard of, diabetes mellitus type 1 and type 2. But rather, diabetes insipidus comes from a problem with ADH. Either not enough ADH is secreted from the pituitary, and that's usually a neurogenic problem. I've seen it associated with severe brain injuries. Or there's a problem with our kidneys' responsiveness to ADH. People with DI have excessive thirst and produce excessive amounts of urine. And the urine is totally clear like water, and basically the kidney is not concentrating the urine at all. The second disease is called the syndrome of inappropriate ADH. And in this syndrome, the negative feedback loop fails to stop the release of ADH. It is caused by drugs, tumors, surgery, pain, stress, elevated temperature. And we talked about the way water is controlled, again, by ADH, but also there is a process of controlling sodium. So if we can control sodium via the kidneys, then we can also control water and water retention. So we're going to talk a lot in this class about the renin-angiotensin-aldosterone pathway. And when this pathway is triggered, it ultimately increases sodium reabsorption. The sympathetic nervous system, fight or flight, also increases the rate at which blood flows into the kidney, and triggers the sodium reabsorption through the activation of the sodium-potassium pumps. And this is just a slide that will review the renin-angiotensin-aldosterone system. As I said, this is you're going to have to know this in this course very well, inside, outside, outwards, backwards. So there are 3 mechanisms in this pathway that focus on sodium retention. So the first one is when the adrenal cortex is stimulated by angiotensin II, it releases aldosterone. And aldosterone is a hormone that promotes sodium and fluid retention. The pituitary secretes ADH, and that promotes sodium and fluid retention. Angiotensin II directly helps us retain sodium. And all of these processes together help to increase blood volume. And we finally reached the finish line for Chapter 8, Part 1. If you'll join me in Part 2, we'll talk more about some of the other electrolyte imbalances.